Thank you, Dr. Shantan. If you could please take the stage. So what we are doing is we are not essentially doing a poster presentation. We are doing a oration or a paper presentation, whatever the case is applicable. Thank you.
Thank you, sir. I'll start with this paper presentation. Good afternoon, everyone. And a huge thank you to Dr. Bismay Kumar sir for providing me the opportunity to present an IR perspective in angiomyolipoma of kidneys. I'm Dr. Sayantan from Intervention Radiology team, NH East. This is our abstract. A 44-year-old female presented with recent onset abdominal pain and flank pain for 2 days. Patient had a drop in hemoglobin to 7.8 and received transfusion, following which hemoglobin levels rose to 9.2. Previous CT done from a different institution revealed an angiomyolipoma with suspected rupture. Imaging at our institute revealed a fat-containing oval to round lesion with soft tissue component. The inset ultrasound shows a large upper pole, partially exophytic, bright mass. The same lesion is seen on coronal views occupying the upper pole of the left kidney. This is indicated by the yellow arrows. The mass was hypervascular and there was an aneurysm, which is indicated by the red arrow. There is a large perinephric hematoma, which is appreciated surrounding the kidneys. This is a video of the pretreatment computed tomography angiography and shows the same findings as described in the previous slide. After a multidisciplinary discussion, patient was given choices between nephron-sparing angioembolization and more invasive partial nephrectomy with perinephric hematoma evacuation. Patient made an informed choice favoring embolization. We planned the embolization on the acquired computed tomography angiography on the standard MIP CT. The AML, which is indicated by the yellow box, was supplied by the second branch of the upper polar branch of the main renal artery, which is indicated by the red arrow. The aneurysm that we saw was also seen on the medial aspect of the mass and is indicated by the blue arrow. For the embolization procedure, the first step was access. This was followed by selective renal angiogram with a SIM1 catheter. This was followed by microcatheter angiogram from the vessel supplying the tumor. Finally, after confirming the position of the microcatheter distal to the parenchymal branches, embolization was done using 1:7 glue-lipiodol. Control runs were taken to confirm preserved normal renal parenchymal branches, and final angiogram showed no further opacification of the arterial tree that is supplying the lesion. The glue cast is very well appreciated on 3D fluoroscopy during CBCT acquisition. Post-intervention CT showed an excellent glue cast. There was no further opacification of the tumor vasculature or the aneurysm. There was no increase in size of the perinephric hematoma compared to the pre-procedure CT, and there was mild incidentally detected hepatomegaly. These are post-embolization images which show no further opacification of the tumor vasculature on arterial phase, and there is an abrupt cutoff of the second upper polar branch as indicated by the orange arrow. The venous phase image shows normal enhancement of the rest of the kidney. This is consistent with the nephron sparing effect. Although the size of the AML and the post-rupture hematoma has not reduced yet, it is expected to in the coming months. Patient was subsequently discharged with plans for yearly imaging follow-up, and successful management was possible through multidisciplinary efforts and impeccable clinical judgments by intervention radiology, nephrology, and urology teams. I will rush through the discussion bit. AML is the most prevalent benign renal tumor. They're composed of blood vessels, smooth muscles, and adipose tissue. They're mainly asymptomatic and incidentally detected on imaging. And sometimes they present with flank pain, gross hematuria, and RPH following rupture. On imaging, there are 3 variants, that is fat-rich, fat-poor, and fat-invisible. Ultrasound is a good screening modality for fat-rich AML. Modality of choice is CT, although MR is more sensitive for fat-poor and fat-invisible AML. Biopsy is reserved especially for fat-invisible AML when CT and MR are inconclusive. The management options can be divided into indications, conservative management, intervention radiology options, and surgical options. The indications for treatment include currently symptomatic patients, especially following rupture, size more than 4 centimeter according to the European Society guidelines, growth rate of more than 2.5 millimeter per year, intratumoral aneurysms of more than 5 millimeter, high risk comorbidities, and high risk occupations like pilots, potential lack of access to healthcare. Conservative management includes medical therapy with mTOR inhibitors like sirolimus or everolimus. These are indicated in tumors more than 3 centimeter in the hereditary group. Both vascularity up to 100% reduction and size up to about 50% reduction have been demonstrated in the EXIST-2 trial. However, this does not exactly correlate with sporadic cases. Sporadic cases show in about 50% patients there is 25% reduction in the size, but more than 50% patients experience side effects of everolimus and sirolimus. I will come to intervention radiology perspective in a different slide. Among the surgical options, total or partial nephrectomy have been the most definitive option for eradicating the renal mass. These treatment options are feasible. All treatment options, if feasible, are preferred over nephrectomy. Intervention radiology in AML. Tissue sampling is investigation of choice through plugged biopsy to differentiate between lipid-poor AML or invisible AML and RCC, which appear somewhat similar on imaging. Selective embolization is the first-line management of ruptured or hemorrhaging AML, and image-guided ablations are second line in embolization failure. They're applicable for all practical purposes in tumors less than 5 centimeter. Thank you for your patient audience. This is a quote that I felt aptly describes the current management guidelines. Thank you, Dr. Abhrajit Raha, sir, for guiding at every step of the poster presentation. Thank you.
How do you different? How do you differentiate radiologically renal cell carcinoma versus this?
Sir, basically, sir, sir, you know the T2 sequence, sir? T2 are heavily fluid sensitive sequences. Because these are benign tumors and there is lack of edema in benign tumors, compared to malignant tumors which have necrosis and edema both, RCC usually have high T2 signal as compared to AML, especially fat poor or fat invisible AML will have a low T2 signal. But there are exceptions, of course. Papillary renal cell carcinoma will have characteristically has a lower T2 signal than the conventional RCCs, other forms of RCCs like chromophobes, X11, P13 variants. So we can differentiate by the T2 signal, sir.
Another question, like as per the literature, what is the most common complication of this procedure and what are the failure rates?
Sir, the procedure is technically successful in 93% patients. So technical failure rates are about 7% immediate technical failure. Overall, during follow-up, the literature says there is about 30% secondary recanalization which require or recruitment of vessels which require a second session of embolization. Sir, what was the other questions? The most common complication in about 43% patients, about 40% patients experience post-embolization syndrome, sir, which is related to inflammatory response following blockage of the blood vessels and necrosis within the tumor. Now, it can be adequately managed with conservative therapy, sir. There's mostly symptomatic management for fever, vomiting, and abdominal pain.
missing kidney. And secondly, AML is a benign condition. So removing a kidney in a benign condition is a big question mark. Even family didn't want that in the first part. So radiologists, they did an excellent job by giving an embolization. Yes, it can re-bleed, but patient was bleeding that time because hemoglobin went down to 9 from 11. And second bleeding also where we had to transfuse this patient. But where this kind of intervention can save a kidney and give the patient an nephron sparing approach, that is why this case was presented.
You can always go for partial.
This kind of kidney is very difficult because the entire capsule is bleeding. So if you have to remove and keep evacuating, you will ultimately ending up removing the entire kidney. That was the discussion by the urologist which they put forward. There was no scope of partial. If there is a tumor which is involving a partial part of the kidney, not bled, then there is a scope of partial nephrectomy. But here the entire kidney is encased in the bleeding envelope. The hematoma is completely involving the entire kidney from upper lobe to lower lobe. You can see in the diagram, in the picture. So that is why the urologist had the opinion that it may end up in complete nephrectomy because intra-op we don't know what is the situation going inside. So that part we have to explain to the patient. But they opted for this and they showed a result. This patient has been discharged yesterday only. We'll do a follow-up CT again after 2 weeks and we'll present this again in the next forum. We'll show you what was the result.
Thank you, sir.
Thank you, Dr. Nice start to our poster presentation. Next, I'd like to ask Dr. Arun R, who is a postgraduate trainee in the Department of Pediatrics, for his session. Thank you. I'd like to request you to please adhere to the time limit.
Good afternoon, respected audience and respected sirs. I'm Dr. Arun, Pediatric PGT, Narayana Super Specialty, Howrah. I am presenting a case which we manage in our PICU. The background history is a one-year-old male child, second born of non-consanguineous marriage from Mullaberia, presented to our emergency with complaints of with mother complaining of increased yellowish discoloration of urine and all over the body, along with child not opening eyes and decreased feeding. Background, one significant history is the child was on INH prophylaxis for positive TB contact for past 1 month. Child was apparently normal till 10 days back when mother noticed the child is having more yellowish discoloration in urine and eyes have become yellow. Child was initially taken to the nearby pediatrician, started on all the liver protective medications after seeing that there is jaundice, but no other investigations were done to rule out the cause of jaundice. And up to 8 days, child was taking these medications. On day 8, child started having mother noticed that child is drowsy and feeding has decreased. The child was taken to nearby medical college where he was found to have hypoglycemia and 1 episode of seizure and was managed there. Since the child required PICU admission, child was sent here. On arrival, the weight of child is 9 kg. Child was drowsy. GCS was 8, tachypneic. Child was icteric. Pupils were equal and reacting to light. Then CBG in our ER was also 28 milligram per deciliter and it was corrected there. On examination, there was hyperreflexia and bilateral extensor plantar. Investigations were sent from a PICU and it showed total bilirubin of 14.8, albumin was 3.8, AST, ALT were in 400s, alkaline phosphate 461, INR was 6.5, ammonia was 50. The evening we sent and next day when we repeated it, it was 128. Potassium was 5 and all the other electrolytes were in the borderline. So from the history and all the investigations, we diagnosed the child to have fulminant child was in acute fulminant hepatic failure in hepatic encephalopathy stage 3 and qualifies as a candidate for early liver transplant as per King College criteria. Child was initially started on all the resuscitation and neuroprotective measures. Counseled parents regarding the child's current condition and that liver transplant is the ultimate option, but there were financial constraints. as a roadblock for the liver transplant. Then cross consultation was done with gastromedicine, neuromedicine, and nephrology. Nephrology consultation was obtained regarding the possibility of ultrafiltration till the child get a definitive management. Then child was started on intermittent hemodialysis with a HA330I cartridge after obtaining high-risk consent. Child underwent three cycles. INR was corrected using FFP. Clinical and the serial monitoring of biochemical parameters were done. There was clinical improvement and biochemical improvement as well. Clinical improvement in the form of GCS became 11/15, and planters started becoming flexor. This is the serial monitoring of investigations. We could see that there was downtrend of bilirubin and ammonia. Then current status is that a couldn't be complete. The child had to be discharged because of the financial constraints. And currently, child is in AIIMS Bhubaneswar, and he's waiting for liver transplant. They are also following the same procedure. In between, child had an episode of sepsis and was managed with escalation of antibiotics after infectious disease consultation. To give a minimal idea about renal replacement therapy, this was the thing which we done. The first one, IHD. These are short cycles compared to CRRT. This was the circuit we used. This filter absorbs all the toxins and bilirubin followed by following which the CRRT will be clearing ammonia mostly. Then we were following this one, CVVHD, because both ultrafiltration and diffusion was taking place. In conclusion is that pediatric acute liver failure is a condition with very high morbidity and mortality. Even with the definitive management, mortality is around 50%. Then peritoneal dialysis is another option. There are only few studies available because of the rarity of these conditions. Then peritoneal dialysis is less effective compared to intermittent hemodialysis because it clears ammonia and toxins at a lower rate. Then IHD is preferred than CRRT because IHD has a higher blood flow rate and the clearance is very fast. Then CRRT is preferred in neonates, especially sick neonates, because in CRRT there is a less risk of hemodynamic instability, hypotension, and hypothermia, which neonates are more prone to. Then it is never a replacement for liver transplant. In a resource-limited country like India, it should be utilized in children who is in need of emergency liver transplant until a definitive management is available. Thank you.
Any questions? Do you think this liver failure is due to INH?
It could be due to NH, sir, but other metabolic, we couldn't, all the serological things were done in our center and nothing came positive. In AIIMS Bhubaneswar, they are now trying to rule out all the metabolic liver diseases also, sir.
You have done the hemodialysis for what?
Mostly clearance of bilirubin and ammonia, sir. Bilirubin and other toxins plus ammonia. Because hyperammonia, high risk for cerebral edema, and like in 1-year-old child, I know there is high risk for kernicterus also, long sequelae.
So your idea of presenting the case is to highlight the role of hemodialysis in
sir.
cases of
Yeah,
hepatic
yes, sir.
encephalopathy.
Yes, sir. Yes, sir. Yes, sir.
See, this case, actually this is not hemodialysis, this is hemoperfusion. Hemodialysis machines can be utilized for many more purposes other than renal failure. That was the purpose of this presentation. This child was having fulminant hepatic failure. That means very high mortality. Possible INH induced, but INH dose was only 100 milligram per day. Baby weight was around 9 kgs. This patient had survival issues. Now, the bilirubin was mounting, his INR was worsening. What else we had an option? We could do liver transplant, but we don't have resources for that. So how can we make the baby survive? So then we utilized the hemoperfusion cartridge, which a newer cartridge, got it down from Delhi. And we used that cartridge to bind the bilirubin through the blood to extract the bilirubin and the metabolic products of liver to do this hemoperfusion. And I'll tell you, this is the world's second case of the lowest birth weight which we have done. First birth weight was Gangaram Hospital with 6 kg, and this is the second case, which is second case in the world which we have done. And this baby is still surviving because we couldn't afford to continue, because each hemoperfusion is a costly affair. So we had to transfer to Bhubaneswar AIMS. So still the baby is waiting for a liver transplant there. Viral markers have not yielded anything, but just to highlight that we do have options to actually bridge the gap before a liver transplant in a case with fulminant hepatic failure, and that was the message. Probably that is correct.
Thank you, Dr. Arun. Next, we have Dr. Pallavi. She is a postdoctoral trainee in the Department of Critical Care Medicine. She will be presenting on an observational study.
Good morning, my respected teachers and my fellow colleagues. Today's topic of my presentation is Incidence and Outcome of Hyponatremia in Intensive Care Unit. It is a prospective observational study. I am Dr. Pallavi Shaha, DRNB Critical Care Medicine trainee of Narayana Super Speciality Hospital, Howrah. Hyponatremia is a common electrolyte imbalance found in critically ill patients in ICU and in 15 to 22% of hospitalized patients. It is defined as serum sodium concentration of less than 135 millimole per liter after excluding the pseudo-hyponatremia. And it is further categorized into mild, that is sodium less than 135, moderate less than 130, and severe less than 125 millimole per liter. The symptoms include nausea, malaise, lethargy, headache, altered mentation, convulsion, and even up to coma. There are insufficient literatures and review articles regarding the prevalence, types of hyponatremia in critically ill patients in ICU and their outcome. And also there was inadequate data regarding the post-hospital mortality and follow-up of such patients with hyponatremia in ICU. So the research questions include: what is the incidence as per different severity of hyponatremia, what are the common etiological factors, and how do the clinical presentation and outcome vary among the study participants. I included the patients admitted in ICU with serum sodium less than 135 millimole per liter and age having 18 years and above. And the exclusion criteria were age less than 18 years, post-operative patients, patients on renal replacement therapy or receiving mannitol and radiographic contrast, patients having hyperlipidemia, hyperglycemia, paraproteinemia and neurological abnormalities, patients with AIDS and new onset hyponatremia during the ICU stay. After taking IEC approval and informed written consent from the patients, total 60 patients fulfilling the criteria were studied for 1.5 years at our setup. Demographic characteristics like age, gender, height, weight, history, including the course of the disease, signs, symptoms, comorbidities, and drug history were studied. Evaluation of volume status like using capillary refilling time, heart rate, blood pressure, jugular venous pressure, skin turgor, lung and cardiac auscultation, routine lab investigations, and parameters of clinical outcome that included development of acute kidney injury, ventilator days, ICU days, and discharge from ICU or death were studied. Data analysis was performed using SPSS version 26.0 and Microsoft Excel 2003. Student t-test was used to compare the categorical data. P-value of less than 0.05 was considered to be statistically significant. There was no conflict of interest and confidentiality was thoroughly maintained. As per the result analysis is concerned, among the 60 observations, 14 patients had mild, 10 patients had moderate, and 36 patients had severe hyponatremia. In the moderate group, 50% patients had hypertension, 100% patients had drowsiness as symptom. In severe group, 63.8% patients had hypertension, 50% patients had drowsiness, and 30.5% had confusion. 42.86%, 50%, and 38.8% in the mild, moderate, and severe groups respectively had renal involvement, whereas SIADH was the most common cause in all the groups. Acute kidney injury was higher in mild and moderate groups, whereas severe group showed higher death rate. Mean ICU days were higher in mild and severe groups. Post hoc analysis revealed significant difference in ICU days for mild to severe and mild to moderate groups. Ventilator days, presence of drug history, and hypovolemia increased the odds of being in a higher category, whereas ICU days, hypervolemia, and acute kidney injury did the opposite. So as per the discussion is concerned, Hawkins in 2003 showed that age is related to the severity of hyponatremia, though the exact mechanism remains unclear. Babelish et al. Found that the patients with severe hyponatremia had higher levels of bewilderment. Patni et al. Found drowsiness as the most prevalent symptom, around 51%. Hypertension and renal disease became more common with increased severity, while ischemic heart disease and liver disease show less association. Panikkar and Joseph found that SIADH was the most common cause. Wojtok et al. In their study found mortality was notably higher in the severe group due to adverse outcome. Corona et al. Showed drug history, hypovolemia, increased severity, length of stay, hospital expenses, thus guarding prognosis and tailoring the management. So to conclude, this study highlights the complex interplay between demographic factors, clinical features, comorbidities, and outcomes, thus guiding the better management strategies to lessen hospital stay and mortality. These are my references. Thank you.
Thank you for finishing in time.
Thank you, sir.
That is very important. You have mentioned that this is a prospective study.
Yes, sir.
How many days you have followed these patients up?
So these patients have been totally followed from 1.5 years at our tertiary care setup ICU, but the study samples were taken for first 1 year and the result analysis were done for next 6 months, total 1.5 years.
Followed the patients up to 1.5 years?
Yes, the patients, the studies have, okay, sir. So this,
Followed these patients up to 1.5 years?
the study participants, it was a prospective observational studies. So I studied the patients for the first 1 year, and the result analysis part was done for the next 6 months. So throughout the study, it was the total duration of the study was 1.5 years.
So how many patients recurred having hyponatremia?
Sir, the patients who were recurring having hyponatremia, they were not included in the study. That was one of the limitation of the study. Actually, the patient after.
I think what sir is asking, what was the study points or visits of the patient that you have captured the sodium, not the study length?
Because you are mentioning this is a prospective study.
Yes, sir.
Follow these
Will
patients
you
up.
follow up till discharge or beyond that?
I followed the patients till discharge or death as per the outcome is concerned.
That is not the point of a prospective study. Prospective study has to be, you have to follow the patients after 6 months or 1 year like that.
After the patient getting discharged from ICU.
This is observation.
Yes.
You are doing only during the stay in the hospital. That cannot be qualified as prospective.
Moreover, SIADH, the new terminology is SAD, not SIAD. Because inappropriate hormonal level does not correlate with the sodium levels. So the newer terminology is syndrome of inappropriate diuresis, not SIADH. Point number 2 is, actually, many of the patients we don't analyze the volume status because subclinical hypovolemia is more than 10%. So if you see the real world scenario, because we miss this subclinical hypovolemia which is more than 10%, the hypovolemic hypometremia is more than SIADH. And did you rule out adrenal insufficiency and hypothyroid in these patients?
Sir, when the patient's causes were elicited in the group, there was a broad group causing due to the endocrine disorders, if the patients are suffering from any. So we assessed the cause as the total group was endocrine disorder, but significantly, particularly adrenal insufficiency group, we couldn't study. In our study, we couldn't study. Yes.
This is your thesis paper for the year.
Yes.
You need to put something in, otherwise you will get caught. Thank you very much.
Thank you, sir.
Good afternoon. My name is Pratik Basu. I am an RMO in the Department of Nephrology at Narayana Super Specialty Hospital, Howrah, Andul. I will be presenting a case of renal osteodystrophy in a patient of CKD. Renal osteodystrophy. Renal osteodystrophy collectively constitutes a group of abnormalities in bone morphology or histology that are an important component of mineral bone disorders among the patients with CKD. regarding our patient is a 22 years old male who is a known case of CKD on maintenance hemodialysis and hypertension. He presented with bony pain, skeletal deformities, and occasionally abdominal pain. On examination, he had short stature, extended neck, abnormal abnormal vertebral curvature, bilateral cubital varus, right genu valgum, and left genu varum, and a pigeon-like chest, which are all suggestive of rickets. On X-ray, he had typical rugged jersey spine, but I couldn't find the X-ray. Renal osteodystrophy is mainly of 4 types. Osteitis fibrosa cystica, which is a high bone turnover disease. It's mainly caused by elevated circulating parathormone levels. And adynamic bone disease, which is a low bone turnover disease due to excessive suppression of the parathyroid glands by medications. And osteomalacia, which can be a low or a high bone turnover disease. And mixed uremic osteodystrophy, which can be presented as combined features of osteitis fibrosa cystica and osteomalacia. Clinical features of renal osteodystrophy: there will be bone pain, there may be tendon rupture, muscle weakness, growth retardation, and skeletal deformities. When to suspect renal osteodystrophy? We have to suspect renal osteodystrophy in all patients of advanced CKD. The prevalence of renal osteodystrophy increases as the CKD stages and its associated metabolic derangements worsen. Parathormone and bone-specific alkaline phosphatase levels, C-telopeptide level, can be measured to diagnose renal osteodystrophy. In patients with CKD, it is important to distinguish renal osteodystrophy from osteoporosis because the management of these conditions are different. An increase in parathormone concentration typically occurs when the estimated eGFR falls below 60 ml per minute per 1.73 meter square. At the point serum calcium and phosphate concentration remains within the normal range until the eGFR decreases furthermore, and approximately it becomes 20 ml per minute per 1.73 meter square. Because of kidney diseases, activation of vitamin D in calcium is impaired, that leads to decreased absorption of calcium and eventually faulty bone mineralization and rickets. Low calcium level triggers increased secretion of parathormone, leading to secondary hyperparathyroidism. Parathormone is responsible for increased bone resorption, leading to increased phosphate and calcium level, but due to renal failure, calcium gets excreted, but phosphate accumulates in longer term. That is why we get hyperphosphatemic rickets in renal osteodystrophy. Thank you.
In cases of renal osteodystrophy, you do the hemodialysis in these patients. Now, what will happen to the renal osteodystrophy if you go on doing that hemodialysis, creatinine comes down, what will happen to this renal osteodystrophy?
So it's mainly a bone disorder, so we have to supplement with.
It's supposed to get better with dialysis and the patients becoming more controlled in terms of CKD.
No, sir, the renal osteodystrophy will not be getting corrected.
Why?
Because kidney function is hampered, and the vitamin D activation is the vitamin D will not be activated properly.
A few points you need to study, huh? Okay. It's okay, thank you.
Replacement therapy, not a hormonal replacement. Okay, so first concept, that dialysis you can remove urea creatinine, but you can no, probably present joint puresis, so you should answer.
Yes, that is what I was asking.
Yeah, so when you have this PTH level, this patient has PTH level 2600. So this is a long-term complication of hemodialysis. So hemodialysis cannot correct metabolic complications of bone disorders, which has to be managed with drugs. Parathyroid hormone starts with hyperplasia as early as GFR of 60. Dialysis is still far. So when we have parathyroid hyperplasia, we have to use phosphate binders early. This is the learning point here. And when these bones become resistant to PTH, this is an example of a high turnover bone disease.
So what is the answer for this patient? We are going for parathyroidectomy for this patient. Now we will present the same case after 1 year and try to show you what was the difference.
There is a list in the standard textbooks where you can get with dialysis, these parameters will improve, this will remain same, and this will deteriorate. Bone disease either remains same or it deteriorates with dialysis. Okay, thank you.
Good afternoon everyone, I'm Dr. Chetna Singhal. I'm here to present a case of hepatitis A
with acute renal failure, which is quite rare. This is my abstract. Generally, hepatitis A is seen in children, and a majority of them presents as an asymptomatic infection. But the incidence of hepatitis A is rising among adults, and more than 70% of them have symptomatic acute hepatitis A. And they resolve spontaneously after having a mild illness like fever, nausea, vomiting, itching, rashes. But less than 10% of them can have extrahepatic complications. Our patient, she was 43-year-old female, presented with fever associated with vomiting, anorexia, followed by yellowish discoloration of eyes and skin. She was a known patient of diabetic and hypertension, well controlled. On presentation, she had INR of 1.6, and after vitamin K injection, it resolved to the normalized 1. The LFTs, as expected, the total bilirubin was high, which was 10.8, and majority of which was direct bilirubin. And the AST and ALT levels were in around 2000. But the odd thing we found was the ABG showed compensated metabolic acidosis, and the creatinine was high, which was 4.4, and within 24 hours, it got up to 5.8, though urine output was adequate. The first thought came to our mind was CKD, as she was diabetic and hypertensive for so long. But the past record shows the creatinine was normal, and the urine ACR was in microalbumin urea range. And on the USG, the CMD was also maintained. So we ruled out CKD and went to the other possible causes of infections, as she was having fever also. And we ruled out scrub, leptospira, dengue, which all IgM was negative. The other causes came to our mind was hemolytic uremic syndrome or the other hemolytic factors. And for that, peripheral blood smear shows no fragmented RBCs, and the platelet was in the low normal range. Though the hemolysis markers, like reticulocyte count, LDH, was a bit elevated, and DCT was 3+, but the heptoglobin was 2.1, which was the higher side of the normal limit, ruling out microangiopathic hemolytic anemias. The ANA HEP2 was negative, and we ruled out lupus nephritis. The complements were low, and in the rare instances of hepatitis A, there can be immune complex injuries to the kidney, which leads to hypocomplementemia and Derek-Combe test leading to positive. The extrahepatic manifestations in hepatitis A can present as acute kidney injury, acalculous cholecystitis, pancreatitis, pleural or pericardial effusions, hemolysis, skin rash, and other neurological manifestations. AKI develops in 1.5 to 7.6% of the hepatitis A patients. The mechanism can be pre-renal azotemia, interstitial nephritis, acute tubular necrosis, predominantly contribute to AKI and hepatitis A, along with intravascular hemolysis, direct hepatotoxicity, or hyperbilirubinemia, or immune complex associated glomerulonephropathy. To know the exact mechanism of the AKI in the Hep A patients, we need to do renal biopsy, which was not feasible for our patient as it will not change any management of the patient. So we prefer not to do it. The risk factors, these are the few risk factors which can lead to AKI in hepatitis A patient. And our patient had few of them, as she was more than 40 years of old, diabetic, and had high bilirubin and AST and ALT levels with low albumin. In non-fulminant hepatitis A, 10 to 50% of the AKI cases requires renal replacement therapy, and so does our patient. We gave her 3 sessions of hemodialysis, which lead to resolving her creatinine, and by the time it was 1.5, and in the follow-up, it normalized to 1.2. Etiology of acute renal failure in non-fulminant hepatitis remain unclear. Thus, in the course of non-fulminant severe hepatitis A, renal functions should be closely monitored. Earlier, the Hep A was common in children only, but as it is the incidents are increasing in adults, the complications are also increasing. It might be the next alarming acute viral hepatitis. Thank you.
Thank you for completing within your time limit. Is this a hepatorenal syndrome?
No.
For the hepatorenal syndrome, we need the chronic liver injury. It should be for long more than 3 months. And there was no incidence of any liver injury earlier, and this was the acute viral hepatitis. So it cannot be the hepatorenal syndrome.
Why you were following the creatinine up? Because the patient didn't have any reduction in the urine volume.
We were following because after giving the first session of dialysis, if it starts resolving spontaneously, we won't start the second dialysis. If the creatinine start dropping out, so we'll just give the one dialysis session and then we can stop it, because the dialysis was the temporary management.
To start with, the patient had a creatinine of 4.4.
Yes, sir.
Is it diabetic kidney disease that is leading to this creatinine?
No,
and
sir.
you have given dialysis, that is why the creatinine is coming down?
Yes, sir. So after, we didn't give the dialysis at 4.4. We gave it at 5.8 when it rose spontaneously within 24 hours. And then it after dialysis got to 3.8. Yes.
What treatment you have given for correcting the INR?
So only vitamin K, because there was no signs of bleeding.
What is the recommendation of giving vitamin K in cases of 1.6 INR?
So in hepatitis A, if it is the INR is 1.5 or more, it can lead to acute liver failure with the symptoms of encephalopathy. There was no encephalopathy symptoms, but to prevent as the kidney damage was also there, to prevent any other further deterioration, we gave just injection vitamin K. It is a symptomatic treatment.
Yeah, and when after how many days was the patient discharged?
So she was discharged within 12 days.
12 days. And what was the discharge bilirubin level?
So discharge bilirubin level dropped to 8.
8. So I had a similar case, and today morning she was discharged. She was a diabetic lady, 85-year-old with hepatitis A, and it's without a chronic kidney disease. She had high creatinine, and with conservative treatment itself, definitely it was not that much. It rose up to 3 only, and every alternate day it was followed. The total count also was around 15,000 for the beginning. She was admitted with just nausea, anorexia and all these symptoms, and with the conservative treatment only she improved, and after a week, today morning she was discharged, and the bilirubin levels had come down to less than 2, as well as the creatinine was also improved to 1.6. Yes. It had come down. And previously, just 15 days before she got admitted, she had all the profile done, and she had come for a follow-up, and everything was within control or normal.
Yes, sir. Okay, thank you. Okay, thank you. Sir. So we ruled out all the possible common causes. First,
if I say this is not hepatitis A related renal failure, it is pigment nephropathy, how will you counter? Pigment nephropathy, have you heard about it? High bilirubin can cause interstitial nephritis that can lead to metabolic acidosis, and pigment nephropathy not related to hepatitis A. Because hepatitis A related to renal failure can be in 2 situations. You can have MPGN or mesenteric polymetallic, which is a biopsy to be introduced. You will have, you've seen written RBC seen, but there will be RBC cast, lot of RBC seen. So that can only be established by doing a biopsy. In this case, if you see the urine output, if it is normal, there is a high chance of having pigment nephropathy in this way, rather than having hepatitis A related.
I get to differ from you. See, for pigment nephropathy, bipigment nephropathy, you have to have a high bilirubin for a long time. If you look at that time span, you will only 7 or 10 days. It is very, very unlikely to be okay. And pigment nephropathy sometimes, while they use the urine microscope, it can be.
That may not always be true, but this is a possibility where it can be there. But to establish hepatitis A related renal failure, we have to have histology to promote. It can be anything, it can be drug induced. It can be, that is true, but this can be a causal relationship between any infection and AKI, which is a normal thing in all the ICU setup. We have infection, you have AKI. But to establish the connection,
we have to think of 2 different. In this case, pigment nephropathy is very unlikely. It might be something else which is caused.
Possibly. It can even be an acute hepatorenal syndrome. That is also a possibility.
Hepatorenal syndrome does not occur.
Acute.
Hepatorenal syndrome does not occur in the
Possibly a pseudo-hepatorenal.
They only occur chronically. Okay? They will occur continually. Hepatorenal syndrome is diagnosed only in cirrhosis.
Pseudo-hepatorenal can be secondary to leptospirosis, hepatitis A infections. It can be in any infection-related acute pseudo-hepatorenal syndrome. That is a likelihood in this. But to establish hepatitis A, earlier we have to have a histology to show mesophageal or empygeal to say that is what is scientifically proven.
But as I said, it's typically very difficult to surprise because it resolves spontaneously.
Yeah, so this is a casual relationship. It can be not an established relationship. Right?
Thank you. That was our last presenter. It was a small but a very nice session. Thank all the judges for their very pertinent questions. Thanks to Dr. Vishwakumar for his inputs. We are honored to have Dr. Dilip to join us. It's great to have Dr. Anivan Kormuka and Dr. Bihan to grace the occasion. Thank you, everybody.
Just, Bisha, just your observation, like, in this particular case, something like this. So was hemodialysis necessary? Because if you hydrate properly, they were...
For metabolic acidosis, which you have, not for the creatinine. Because it was not
Because neither there was a fluid sequestration nor a fluid output was less, neither
it was for metabolic acidosis there. To correct the metabolic acidosis. That's the indication for that. Another thing is, post-dialysis creatinine doesn't have any value. Invariably it will be less. It is better to have a pre-dialysis creatinine, which is the creatinine of the morning, where you have to take the decision on diet, which is more important.
just the other way around, like the pre-insulin sugar level has no value. Because what you are targeting is one thing.
Because many of these patients who are on maintenance hemodialysis of that track and discussing or anuric renal failure, creatinine is done daily. That adds to the bill of the patient. It's not necessary to check creatinine for anuric renal failure.
Thank you. We will conclude the session. Thank you, judges. Thank you, judges. Time for lunch.